A very good morning to all. So now we are going to start this session, which is Dr. A.K. Mehrotra Best Poster Award, which will be judged on poster podium presentation. So very good morning to our respected judges, Dr. Pradeep Kumar Mohanta sir and Dr. Ashwini Kumar sir. So the first presenter is Dr. Prasanna Venkatesh Ramesh. She will be presenting on the topic Human in the Loop Machine Learning for Automated Assessment of Anterior Chamber Angle in Glaucoma.
Thank you for the opportunity. So my talk is on human in the loop learning. Yes. So artificial intelligence is not a hype anymore, my dear friends. It's real and happening. And it started from the simple phone that we used to unlock with our fingerprints, right? As well as there is an automated car, as well as there is an unmanned flight that you can see, which is all been possible. And there is a black box dilemma in AI. We never really know why the AI predicts the way it predicts. So to overcome the black box dilemma in AI, so we have created a convolutional neural network approach using true confocal fundus images. And the neural framework of the AI is similar to a human nervous system, where you can see that there is a algorithm which has to undergo a growth from a baby to an adult, just like a normal human being. And a visual object training tool or a tagging tool was used, and there are two human interfaces. So why utilizing human intelligence is very important is humans monitor the marking of the AI and humans monitor the validation and the predictions of the machine. So these are the 1400 data that we started with the fundus, where you can see not only the machine is thought about the diagnosis, all intricate small findings like a cup, a disc, a peripapillary atrophy, and the final annotation is very huge, where there is 16 to 25 minutes that may be taken for a single image. And these are the AI objectiveness loss, classification loss, which actually decreases, meaning that the AI is actually learning with time, with precision and recall. So if you see, there is, when you upload this image, not only the diagnosis comes, but also when there is an RNFL defect. See the RNFL defect that the AI really gives you, along with the cupping as well as the laminar dot sign, all simple points. You can see that even intricate signs comes. So that's the idea of creating an explainable AI with good sensitivity and specificity. So with that, we wanted to push to the angles of the anterior, and this was the modality that was followed here, where you can see this protractor that has been made. First, the scleral spur is detected, and manually a red dot, a 500 micrometers anterior, the trabecular meshwork is detected, and a perpendicular line is being drawn, and then you get the triangle here. So this triangle you can see, and then the protractor that we are getting, and you get the angle 36.46 degree, and then you show the machine. It's basically human intelligence that we use to really guide the machine, and UBM, Anterion, ASOCT, and Scheimpflug images. So all the four anterior segment modalities were trained for 1500 images, meaning 1370 went into training, and the remaining 130 images. So the training and the testing images were different, and that is how they were split up into. And these are the training results that has been done in phase 1, phase 2 and phase 3. And you can see the lowermost green chart here, meaning that again when it comes lower and lower, that means the machine is learning better and better. So test 1, test 2 and test 3, see what happens among the 130 images that we took. So every 2 months when you increment, or every initial phases, 50, 35 and 45 are the split up, and see the sensitivity and specificity, 82, 92, 88 and 94. So slowly it's starting to learn, and it's now at 95 and 95 in sensitivity and specificity. And this is the annotated image that we do. And when you are training and get the image 1, see what is the anterior chamber angle. It is 24.76 and the predicted is 27. There is a difference of around 3. Then you can see it is a difference of only 2 in the test 2. And finally in test 3 you can see the 24.7 is almost close as 23.1. So it's coming as close as possible. So this is an offline app where you just need to take the image of the anterior segment OCT or the anterior or the UBM. You just need to take it and drop it. You can see I'm just dropping the image into the app, and once you drop the image into the folder of this particular application, so you get the plot points along with whether the angles are wide open or whether it is narrowed, and this really helps you in a simple smartphone analysis of offline application, where you will be able to just put an image into it and get the structures. So another thing is the bimodal AI, which we are incorporating for the OCT as well, and this is algorithm that we have devised, and this is where you will be able to grade the glaucoma. So my dear friends, it's a smartphone era that we are moving into, and the growth of the AI has to be similar to a baby where we are using human intelligence, and this is within 60 seconds of chair time. Fundus AI gives you diagnosis and intricate findings. Angle helps you in differentiating the decision making for YAG-PA, and then we have the OCT AI for grading the severity. So with all these three components, we get a comprehensive glaucoma AI tool, and this is the schematic plan for the future where MIGS is coming in. So these are different MIGS surgeries where we'll be needing this to analyze more of post-angle dynamics even in MIGS surgeries. So thank you once again for the opportunity. It's finally for the community that we are doing. Thank you.
It was very nice. Can you elaborate how did you take the anti-segment angle pictures?
Sir, the concept of this was to use human intelligence along with artificial intelligence. That's why we are bringing in two levels of human interfaces. So we wanted to move towards Anterion because with the advent of MIGS coming into play, the Anterion is one of the imaging systems that's able to visualize the angle post an angle surgery. So that is why we went into Anterion, but there were no real markers or protractors that were available, just like for an ASOCT that is available today. So the images were taken after the acquisition was arrived, and without any processing, it was went into the annotation levels where we had to do the marking, which was what the protocol that I just showed, sir, with the two arrows that were there, and the video showed how the protractor was actually made. Yes, sir.
Thank you, Prasanna. Thank you.
Excellent
Thank you,
sir.
presentation.
Thank you for the opportunity.
Yes,
Next one.
By Dr. Pratik Nisant on ocular surface inflammation following accidental administration of topical salicylic acid based traditional medicine.
Good morning, esteemed panel, ladies and gentlemen. Ocular surface inflammation following accidental administration of topical salicylic acid-based topical medicine. I have no financial interest. Accidental chemical injury to the eye may occur from lime, paints, superglue, cleaning agents, pesticides, industrial solvents, and environmental pollutants. Published literature has infrequently reported such an injury due to inappropriate topical application of a traditional medicine. 2 patients presented after inadvertent ocular administration of a topical lotion containing salicylic acid, benzoic acid, and alcohol named Dadurin, which is marketed as a traditional medication for dermatological conditions. After exposure, both patients had washed the affected eyes immediately with tap water, and both patients were carrying the bottle of the incriminating agent at the time of presentation. So this happens to be the incriminating agent. This is the box of the medication mentioning the indication, which is ringworm and tinea in Hindi. This is the composition consisting of salicylic acid, benzoic acid, alcohol, and about 78 to 82% alcohol content. This is the eyedropper bottle containing that topical lotion, and the labeling on the medication bottle is poison. So the first case was of a 28-year-old male who presented with redness, mild pain, watering, swelling following a drop of Dadurin in place of olopatadine 0.2% for itching. The visual acuity was 6/6, and left eye showed eyelid edema, conjunctival ecchymosis, and conjunctival congestion on the nasal side with a corneal epithelial defect straddling the inferior limbus. The IOP was normal and the right eye was normal. The second case was a 56-year-old female who presented to the OPD with redness, mild pain, watering after the installation of Dadurin instead of brimonidine plus timolol for diagnosed primary open-angle glaucoma. The unaided visual acuity was 2/60, and a large corneal epithelial loss of about 11 millimeter into 7 millimeter was seen in the right eye with conjunctival and ciliary congestion, chemosis, matted eyelashes, and again the IOP was normal, and the vision, part of the visual acuity was down also because of immature cataract. So topical moxifloxacin and loteprednol was given over 1 to 4 times daily, and carboxymethyl cellulose lubricants 1 to 4 times daily were prescribed for 2 weeks for both affected eyes. The anti-glaucoma medication was switched to a preservative-free formulation. At 2 weeks, the symptoms and signs had improved and the epithelial defects were healing. Subsequently, the eyes achieved normal epithelial integrity and are maintained on lubricant eye drops. There was no evidence of limbal stem cell deficiencies, and both patients were symptom-free at 2 months of follow-up. So at the follow-up examination, at 2 weeks follow-up, this is how the epithelial defects were seen to be healing, and this was satisfactory clinically. So ocular surface burns comprise of about 7.7% to 18% of all ocular traumas. Previous studies of accidental chemical injuries are limited to household or industrial agents, with occasional reports incriminating formulations of alternative systems of medicine, particularly Ayurveda. Only 2 earlier reports of ocular surface injury with salicylic acid-based chemical formulations have been found in published literature. Our patients admitted that similarity of packaging between this medication and routinely used eye drops, which is the white dropper bottle with conical top, was the cause of confusion, which is likely why they instilled the agent into the eye. So the drugs that look alike but are intended for different recipients are known to have such risks, which are stored in pharmacies and households with distinct labeling. Previous case reports have recommended the packaging of these lotions to be easily distinguishable from eye drops. However, the manufacturers have not modified the packaging accordingly. The patients with low vision may have an added risk of self-induced chemical eye injury, which is further compounded by this confusion. The ocular surface injury from salicylic acid can be mild to severe due to astringent action. It can have epithelial defects or sloughing, non-healing epithelial defects with loss of limbal stem cells and blanching, may need surgical intervention, and may culminate in corneal opacities and vision loss. In conclusion, ocular medication errors from lookalike drugs can have to be prevented and needs policy intervention owing to immediate washing off of the offending agents. Our cases had limited disc formations and culminated in good recovery, fortunately, but I would recommend that this be taken up on priority from the AIOS as well. Thank you so much.
Good, Pratik. Is there any commercially available preparation of this? What's the name?
Pardon, sir?
Any commercially available preparation of salicylic acid-based traditional?
The Dadurin that the eyedropper bottle that was showed, that is exactly the same commercially available preparation is marketed all over India, sir.
Okay. Is it very irritating to the eye?
Yes, sir. 78 to 82% alcohol content means that there will be immediate desloughing of the corneal epithelium, and it will be very irritating, sir.
So, how to prevent that? Do you use any anesthetic like proparacaine before applying this?
Sir, it is not intended to be applied in the eye, but the similarity in packaging with the eyedropper bottle is what the patients are confusing it with, and they are putting it inadvertently into the eye. So that is something that needs the policy intervention.
Very, very well presented, Pratik, and it's a very pertinent discussion to be had of how we can make changes and make sure that these kind of drugs are banned and not to be used by chemists. Thank you very much. Very well presented.
Thank you, sir. Pardon, sir? Pardon, ma'am? We did not use any neutralizing medicine as such because the patients presented late. If the immediate presentation is there, then the protocol to be followed is the same. The patients had already washed their eyes with sufficiently with the water, so that is why the repeat washing was not required.
After cleaning it, what are the delayed side effects?
Pardon, ma'am?
Delayed effects of this.
The delayed effects of this medication are as shown in the case reports, ma'am. There is desloughing of the corneal epithelium, and it is like any other alcoholic chemical injury.
It ends with the phthisis or what?
If it is very severe, ma'am, it may end into phthisis, but fortunately our patients washed the eye immediately with tap water, so the recovery was good. The insult was not that severe.
Does it need the keratoplasty or anything?
It can need keratoplasty, ma'am. There can be very severe ocular surface burns with salicylic acid itself as well as salicylic acid based lotions. There are 2 case reports which are showing, one with this very intermittent agent, which is Dadurin, and one is with 20% salicylic acid based lotion. That is for a separate indication from a foreign author.
It was pure salicylic acid or something else was made?
Salicylic acid, benzoic acid and alcohol in this case report,
So
as well as one more.
How you can say it is due to salicylic acid? It can be due to benzoic also.
In the interest of time, we'll move on to the next one.
Okay.
Thank you, Dr. Pratik.
Thank you, Dr. Pratik, and very good morning to Dr. Piyush Bansal, sir. So the next presentation is by Dr. Subhangi Shahu to report a rare case of orbital apex syndrome secondary to nasopharyngeal carcinoma.
Good morning to all. I, Dr. Subhangi Sahu, shall be presenting a rare case report on orbital apex syndrome secondary to nasopharyngeal carcinoma. The case is of a 44-year-old female who complained of pain in the right eye, which was associated with blurring of vision and dryness since 4 months, for which she had consulted a local ophthalmologist. She was prescribed glasses and topical lubricants, but it was not of much use. This was followed by complaints of nasal bleeding for the past 2 months. This was associated with fever and headache. She was on antihypertensives. On CNS examination, there were multiple cranial nerve palsies, and on ENT examination, there was left TNS with nasal polypoid mass in the right nostril. On ocular examination, the best corrected visual acuity was counting fingers close to face, and near vision was less than N36. Color vision contrast sensitivity was not available for the right eye. Lid and adnexa had mild to moderate ptosis and mild proptosis. Shermer's 1 test revealed mild dry eye. The right eye also had intact corneal sensations. Pupils were having grade 2 RAPD. Fundus had a temporal pallor of disc and retina was on. Left eye was essentially within normal limits. On strabismus workup, this is the standard 9-gaze picture. There was no abnormal head posture or DVD. On modified Krimsky test, there was 25 prism diopters of right exotropia with 4 prism diopters of right hypertropia and -1 abduction and depression limitation. On MRI brain and orbit with contrast, there was a large ill-defined heterogeneously enhancing solid mass with central areas of necrosis and hemorrhage involving the right nasal cavity. This lesion was abutting the right medial rectus, inferior rectus and superior oblique with narrowing of the right optic canal and involving of the orbital apex. This was suggestive of right orbital apex syndrome. The MRI brain with contrast and CT angio of brain and neck was also done, which was within normal limits. On careful workup of nasal endoscopy with polypectomy and biopsy and histopathology of resected specimen, the diagnosis came to be nasopharyngeal carcinoma, so which brought us to the final diagnosis of right eye orbital apex syndrome, secondary to nasopharyngeal carcinoma with mild dry eyes. This case was then managed with topical lubricants and radiotherapy. Now, coming to review of literature, nasopharyngeal carcinoma is a tumor arising from epithelial cells that cover the surface of the nasopharynx. It most commonly presents as cervical lymphadenopathy with bone erosion. Intracranial extension can present with visual impairment. It is particularly uncommon in India. However, it is a highly radiosensitive lesion. Therefore, the best modality of treatment is radiotherapy. So to summarize, orbital apex syndrome is characterized by vision loss, ophthalmoplegia, ptosis, and may or may not be associated with hyposthesia and reduced corneal sensations. And it can have varied etiologies such as inflammation and infection, etc. So the take-home message from my presentation is that nasopharyngeal carcinoma is one of the most easily misdiagnosed tumors as it doesn't present with nasal symptoms initially. The initial presentation will depend on the tumor location and extension. A careful clinical workup and relevant lab diagnosis is the crux to establish the correct diagnosis. Till date, very few literature reports are available with nasopharyngeal carcinoma presenting as orbital apex syndrome. The visual prognosis in these cases depends upon the visual acuity at presentation and extent of involvement of the optic nerve. Thank you all.
Very nice case. Was there any improvement in vision after radiotherapy?
Yes, sir. There was not fully recovered, but there was some amount of improvement.
You must quantify that some amount of improvement, no?
Yes. Yes, sir.
So you can tell us how much the visual improvement was in terms of Snellen or ETDRS charting.
So from CF it came to around 636 and
That's
near
good.
vision also around N18 it came around.
Very nicely presented. And just avoid using short forms when you're making a presentation.
Sure.
Rest everything was very nicely done. Thank you, Dr. Saab.
Thank you, sir.
Thank you, Dr. Subhangi. Now the next presentation is by Dr. Vipin Rana on recurrent panuveitis in Pike 3 CD disorder.
Good morning, everyone. Today I shall be presenting one of the rare cases. So, activated PI3K delta syndrome is a rare genetic disorder which is characterized by the immune system dysfunction, primarily because of the affection of the T cells. And we report a challenging case of recurrent panuveitis in a young patient caused by a novel variant in a PIK3CD gene. To the best of our knowledge, this association has not been reported before. So, my patient, 15-year-old male, In 2014, while he was 8 years old, he was found to have decreased vision in both eyes on retina examination during the school retina examination, and was diagnosed to have an intermediate uveitis at center A and was started on oral steroids. However, these were stopped in 2015. In 2016, again he presented with diminution of vision at center C and was again diagnosed intermediate uveitis, again given a course of oral steroids on and off. 2018 underwent tonsillectomy in May 2018, and in June 2018 was diagnosed to have Hodgkin's lymphoma mixed cellularity stage 2A. So underwent 4 cycles of chemotherapy, and oral steroids were again started along with the tablet methotrexate 7 to 8 months after the remission. So in 2019, a patient again had vision deterioration and was again started on the oral steroids and tablet MMF. So underwent cataract surgeries in the both eyes, and in 2023 he reported to our center with complaints of diminution of vision in both eyes. So on presentation at our center, he was on tablet prednisolone 10 mg OD and tablet MMF 500 mg thrice daily. On examination, his anterior chamber, the cells were 2+ in both eyes, and the visual acuity was best corrected in the right eye was 6/18 parts, and in the left eye it was 69 parts. And in the fundus examination, we can see the multiple dense vitreous membrane were present in both the eyes. So FFA showed in the right eye there was a diffuse capillary leak along with cystoid macular edema in the left eye. So we started, patient was started on this tablet MMF, and tablet oral steroids was high. But on tapering the dose, in April, patient again presented with the recurrence. Vision deteriorated to 6/36, and the right and left 6/9 parts. And again, on FFA had capillary leak in right as well as the left eye, with presence of the petalloid appearance suggestive of the cystoid macular edema. So the plan was either to change immunosuppressive agent, add another immunosuppression, or start biologics. And in the meantime, the consultation of the pediatric rheumatologist was taken. And for the timing, the patient was given injection Ozurdex in the right eye. And post Ozurdex, vision improved to 6/9, and we can see the significant decrease in the vitritis. So the whole exome sequencing was sent, which showed in exon 8 there was PIK3CD mutation, and which was further confirmed on the Sanger sequencing. And OMIM phenotype described for the variant was autosomal dominant immunodeficiency 14A with lymphoproliferation. And immunological profile was also suggestive of the same, with increase in the IgA and IgGM. So the final diagnosis was APDS with bilateral panuveitis with Hodgkin lymphoma, and patient was continued on the same treatment, and further we added the subcutaneous methotrexate after the consultation with the pediatric rheumatologist, and the parents were counseled for the hematopoietic stem cell transplant. So to conclude, a novel PIK3CD mutation expands the spectrum of known mutations and highlights the need to consider genetic causes in patients with recurrent treatment-resistant uveitis and systemic infections. And it is imperative that the patient and family members are counseled for the condition and its implications for the patients as well as the family members, and it needs a multidisciplinary approach. So take-home message is: young patient, recurrent infections, not responding to the treatment as expected. Start thinking out of the box. These are my acknowledgements. Dr. Mohit Dogra, Dr. Ankush Jindal, PGI Chandigarh, Dr. Vamshi Krishna, Lalpath Lab, and my resident, Dr. Nandan Tripathi. Thank you so much.
Thank you, Dr. Rana. Excellent case that you've discussed. One thing I would also like to highlight is on the angio, on the fluorescent angiography, there was a large area of ischemia also there. So apart from the Ozurdex that you had injected for the macular edema, it's very likely that this patient is going to come back with perhaps neovascularization. So it is definitely going to be required that you either consider a scatter laser or perhaps keep the patient on anti-VEGFs also, especially since he's a young boy. Very nice presentation.
Thank you so much, sir.
Thank you, Dr. Bipin. Now the next presentation is by Dr. Anashua Kapoor. Is he present here? Then the next presentation is by Dr. Pratibha Kataria on clinical and magnetic resonance imaging analysis and myopic anisometropia.
Good morning, everyone. Where is this showing?
She's unsure. Pratibha, she's Pratibha Katar.
Sorry, but my presentation is not listed in this list. Yes. Should I wait?
If anybody else is available, because I think they've not sent your presentation, don't worry. We'll probably go on to the next one and we'll take yours once it comes in.
Next, is your name?
Dr. Raghav Preetham.
Dr. Raghav.
Ankit Agarwal is here.
And perhaps it's a good idea to make sure that the next one is also available.
Preetham.
Yes, the first one.
Good morning, everyone. At the outset, I would like to thank AIOC for giving me the opportunity. Today, I would be talking about amantadine keratopathy. Is it a myth or reality? Let's look at a case of a 62-year-old lady came with blurring of vision for 4 months, which was painless and sudden in onset. She had occasional watering and foreign body sensation. She is a known Parkinson's disease patient with CKD and dyskinesia as well. She has been using amantadine 100 milligrams BD for the past 15 years, along with carbidopa, levodopa and entacapone. Past ocular history, she's visited 3 ophthalmologists before me, including 1 cornea surgeon. She was treated with repeated doses of steroid, Rho kinases like netarsudil and sodium chloride for the past 2 months. Both eyes were planned for endothelial, both eyes were diagnosed as endothelial dystrophy and planned for a transplant. This is on presentation. The vision in both eyes was around 20/100. Patient had DM folds with altered anterior corneal reflex with stromal edema. IOP was within normal limits. This is the anterior segment OCT, which showed increased pachymetry in both eyes with a wavy pattern of DM posteriorly with altered stromal reflectivity. Differentials at this point of time were herpes disciform keratitis, but it was not so because of the absence of cellularity in the stroma. There were no KPs on the endothelium as well or previous scars. Fuchs was also ruled out because in the periphery where the cornea was clear, we couldn't see any beaten bronze appearance or we couldn't see any of the guttae. It was completely non-inflammatory, so all the inflammatory causes were ruled out, which shortlisted the diagnosis probably due to drug-induced keratopathy. Because it's a very rare diagnosis, I went through literature and we could find 21 cases overall, and we tried to match the demographics and the profile to the case. So it is more common in female, like in our case, of aged around 50 to 60, more common with Parkinson's disease, who are using amantadine for dosage of 100 milligrams per day. So I wrote a letter to the neurologist asking him to stop amantadine. Thankfully, he stopped and switched it to pramipexazole. Topically, I started the patient on prednisolone acetate 4 times a day along with lubricating drops. As you can see, on day 10 of stopping amantadine, the posterior corneal edema is slowly coming down. However, the anterior corneal edema with few bullae are still persistent. By day 45, the cornea became more compact. Only mild anterior corneal irregularity persisted, and the vision improved as well. And by day 75, the cornea became clear. There was NO4 grade cataract. With refraction, the patient was improving up to 6/9 vision in both eyes. So what are the unique features of my case? So this is the longest lag time from the initiation of therapy. In literature, the other longest case was 10 years. We have 15 years, which documentation you can see on the right side where she started at around 2013. And there is complete reversal. The last case in literature which had more than 10 years had to go transplant. Despite having coexisting kidney diseases and such long lag time, presentation is also very rare and also presented with near bilateral symmetrical corneal edema at presentation. Thank you.
So how did you treat this case?
So, to start with, I asked the neurologist to stop the medication. The amantadine stopped and I just gave patient symptomatic relief with lubricants and topical steroid because of the surface inflammation. I tapered down the steroid. As the drug washed off from her system, the cornea improved on its own.
Became clear totally?
It became completely clear, yes. Otherwise, the patient was already planned for a transplant as well. Just by stopping the drug, the cornea came back to completely normal state.
Great, nice case.
Nice presentation. So, is it a myth or reality?
Reality for who believe in it. Myth,
so people like me who don't know encounter
because I get this a lot, because I don't have a way to prove it, in the sense that I don't have a diagnostic test to say that amantadine actually caused the corneal edema. So the speculation will always be there.
What about literature search?
Literature search, there are around 20 cases overall in the world, and they have similar kind of presentation, and the demographic status is similar. The amount of amantadine taken, the vision dropped to 20/100. So there are similarities which match the literature which has already been published.
And what are the other side effects of amantadine that are documented?
Amantadine related retinal toxicity
Not
has
just
also.
retina, overall in the body.
So it can lead to kidney disease as well. So this patient was having the chronic kidney disease. Despite that, neurologist wanted to persist with the treatment because it was working for him. And what happened immediately after stopping amantadine as well, the patient started having more movements. They were even more worried, saying that you asked us to stop the treatment, now my movements are getting worse, I can't see. But I just reassured them, saying that this is the way of treatment. Slowly with pramipexazole, she could cope up with her daily activities and corneas improved, so they gained more confidence.
And is it maintained? The corneal clarity
is completely maintained. The clarity is maintained, and we have planned her for a cataract surgery.
That is good enough reason to say it's reality then.
Thank you.
Thank you. We have Ankit there sitting away, so if Dr. Anushwa is also there.
First of all, I would like to thank AIOS to give me the wonderful opportunity to present here. The topic is innovative low-cost dry eye treatment. Now, dry eye is defined as a dysfunction of lacrimal functional unit, which is an integrated system comprising of lacrimal glands, ocular surface, lids, sensory motor nerves which connect them. Most of the dry eye in India is associated with MGD. It is because of the systemic issues like diabetes and the weather here is tropical in nature, the dust and etc. So the treatment modalities which are available right now, it includes topical lubricant drops, anti-inflammatory agents, cyclosporin, steroids, etc. So the various device-based therapies have come up in recent years. The two main devices which are in the market, they act by increasing meibomian secretion either by heating and expression, that is LipiFlow, or reducing meibomian inflammation, that is intense pulse therapy, that is IPL. However, these devices are very costly and hence the cost of therapy also increases proportionally. Keeping this in mind, we have designed an innovative approach to a dry eye treatment wherein a low-cost device is used which provides a similar effect to what a LipiFlow achieves. The purpose of this study is to describe an innovative low-cost dry eye therapy system as compared to a much costly alternative available in the market. The study was performed at an eye hospital in North India, situated in an urban setting. The therapy protocol was designed wherein a low-cost eye heater cum massager, which was easily available on Amazon for rupees 10,000, was used to treat dry eye diseases caused due to meibomian gland dysfunction. The data of 39 patients aged between 43 to 59 years was collected, and of these, 27 patients underwent therapy using the novel device, whereas 12 patients underwent therapy using traditional method of warm compresses and massage of eyelids twice a day. Now this is the eyelid massager cum heater which I used for the therapy. Now this is how the patient wears it. Now what happens here is that this maintains an optimal temperature of about 42 degrees Celsius continuously. So a good massage is, a good therapy of heating is achieved. Apart from this, it has warm compressor at specific points on the lids so that a meibomian massage is obtained. Apart from this, also it has vibration therapy. The device is used for 15 minutes at a time, once every 3 days for 15 days. That is a total of 6 sessions were done in 15 days. And at the end of 1 month and 3 months, the following diagnostic tests were carried out. That is Shermer's test, TBUT, and an OSGI questionnaire. All the patients were prescribed 1% CMC eye drops. The results of these 3 tests were compared with those of traditional therapy group and with values from before treatment. Thus, the low-cost device reduced the incidence of MGD at 1 and 3 months as compared on normal post-treatment Shermer test and tear film breakup time. The traditional treatment group also has significant improvements in their Shermer's and TBUT values, especially at 3 months therapy. The patients in both were symptomatically much better from before therapy. At 1 month of therapy, the patients who underwent treatment with a novel device had much improved Shermer's and TBUT values as compared to traditional treatment group, showing that the novel device treatment therapy give faster resolution. At 3 months, there wasn't much difference between the two groups. Now, this was the therapy. Now, at mean pre-treatment Shermer's values were something coming around 25 mm. This shows there was a lot of inflammatory watering due to MGD. Now, as the treatment was done with traditional therapy as well as with the device, the Shermer's values decreased at 1 month and 3 months. At 3 months, both the values are appearing similar, but at 1 month, the novel device gave a faster Shermer resolution to approximately 16 millimeters at 5 minutes, which is within the normal range. The TBUT values also increased significantly, showing a resolution in MGD. Thus, this innovative solution is a low-cost dry eye treatment alternative to devices which are available commercially, and thus makes the therapy accessible to a majority of doctors and patients who otherwise would not be able to afford to buy them or pay for their therapy respectively due to financial constraints. Thank you.
What's the name of that massager?
So it's available generically as an eye massager. But what we can do here is that when we connect it to the computer, there is an option that I can modify the time, how much time it can run continuously. Like generically it is running for 5 minutes only. But I changed it in the software to make it 15 minutes continuous running and stopping automatically to make the therapy more.
So does it massage from anterior to posterior or above downward?
Anterior to posterior, so like this.
So idea is to massage the meibomian gland and express out the contents?
Yes, sir. So even with the anterior to posterior massaging, sir, because of heating, the meibomian orifices are loose now. Because the meibomian, the secretions are loose. So when anterior to posterior massage is also done, some amount of secretion will increase.
So how do you do it? Do you keep some tissue paper first, then that
Yes,
device?
I keep a butter paper before putting that, because I have to use the same device for a next patient also. And with the secretions and all, the device will become very oily. So I keep a butter paper first, then I keep the massager above that.
Good, very good.
Ankit, you've done a very nice comparison between your device and traditional therapy. So what was the traditional therapy that was done over here?
Sir, warm compresses and massages. That's what we tell to the patient with MGD. That
this traditional therapy was done every day?
Yeah, I
tell
them to do.
Or did you have a protocol that like similar to the machine, once in 3 days?
No. The traditional therapy, I tell the patient to do twice a day for 10 minutes.
So please keep it on silent.
I tell the patient to do twice a day for 10 minutes.
And then why did you decide to do it once in 3 days? Is it purely because of logistic issues? People
the patient will not be able to come daily to me and might not be able to come twice a day to me. So once in 3 days. And what I found after doing for first 15-20 patients, that the device was having the effect for continuously for 3 days. For 3 days the patient was not feeling too much problem, but then when they started, first I started with daily. When the patient started complaining that it's not possible to come daily, then I started increasing it.
What about the type of patients over here? Were they moderate dry eye? Were they severe dry eye?
They were moderate dry eye. So for severe dry eye and the patients with Sitka kind of conjunctive dry eye, this device doesn't work. This device works only with patients who have the dry eye which is associated with meibomian gland dysfunction, that is watering epiphora type dry eye.
The device has been designed by you, or is it commercial?
No, sir, it's not device.
So is it commercially available?
It is commercially available on Amazon, sir.
Good, thank you.
Thank you, sir.
Thank you, Dr. Ankit. Now the next presentation is by Dr. Pratibha Kataria on clinical and MRI analysis in myopic anisometropia.
Good morning everyone. Myself Pratibha Kataria and I am a project SRF in one of the projects funded by SERB. So my topic for presentation is clinical and
Speak a little loudly, doctor.
My topic for presentation is clinical and magnetic resonance imaging analysis in myopic anisometropia. We have grant support from Scientific and Engineering Research Board, which is now known as Anusandhan National Research Foundation, ANRF. My co-authors are Dr. Zia Chaudhary, Yashwant Singh, Manavdeep Singh, Prabhas Shekhar Mishra. I will be discussing about myopic anisometropia, which is characterized by asymmetrical myopic refractive error in the eyes of the same individual. There is no unifying postulate that explains how and why two eyes within the same environment and identical genetic influences develop asymmetrically and produce different refractive errors, sometimes leading to amblyopia and loss of binocularity. This unique pilot study analyzed extraocular muscles, characteristics of the less myopic globe acting as an intrinsic control for the more myopic globe in subjects with non-strabismus myopic anisometropia of 3 diopter or more by high resolution fast spin echo T2 weighted surface coil orbital magnetic resonance imaging 3T Siemens Skyra. So we used the methods and we analyzed 13 subjects of average age about 20 with anisomyopia with the subject fixating at the center target. 2 mm thick contiguous quasi-coronal images planes were used and they were analyzed for extraocular muscle pulley locations, cross-section and LRSR band length, while quasi-sagittal and axial planes were used to measure rectus, eoma and optic nerve length, all by ImageJ software as per the published norms given by SERB. A comprehensive ophthalmic evaluation was performed in all subjects and clinico-radiological correlation was performed. So we found that when we analyzed all the parameters, we found that there is a marked defacement and lengthening of the LRSR band in more myopic eye versus the less myopic eye. And the average refractive error in the more myopic eyes was also more in more myopic eye than the less myopic eye. But other parameters like rectus extraocular muscles, length and pulley positions as well as optic nerve length, they were all similar, they were not significantly different. We analyzed and we calculated all the parameters and this table shows that we have found the significant difference only in LRSR band length and refractive error but not the other parameters. So these pictures show the right eye which is more myopic than the left eye, shows eyeball elongation is a conical form in the right eye which is more myopic on axial scan. If we see the sagittal scan, this also shows the conical formation of globe. And in the quasi-coronal scan, you can see the more LRSR band attenuation. And
can you show it to us with the pointer and the mouse?
1 second. Can you see this LRSR band is little longer than this one, which is in the left eye. And here you can see the larger eyeball in the more myopic eye than this one, the less myopic eye. these results we found while we analyzed all the subjects. And similarly, our conclusion is this, that in all the subjects we found the difference in the LRSR band and refractive error, but other parameters were more or less similar in all the subjects. And I am also analyzing other subjects also. Our analysis are going on, so we will further conclude when our subjects will be done. And thank you.
Good, very nice, very interesting. Thank you very much. Anybody has any questions from the audience? Okay, thank you, doctor.
Ma'am, if we see that myopic anisometropia, already we know that in a same individual, if both the two eyes grow differently, even in the same environmental and genetic influences. Why this happens? So we are just dealing with these things. We are finding why these things happen. Like two eyes, how they can grow asymmetrically. Yeah. Yes. Yes, ma'am. Yes. Thank you.
Thank you, Dr. Pratibha. Now the next presenter, Sama Hanif, to study the association between serum uric acid level and age-related macular degeneration.
Good afternoon, everyone. I'll be talking about the serum uric acid and age-related macular degeneration. Age-related macular degeneration is a late-onset, multifactorial neurodegenerative disease which is characterized by progressive degeneration of the photoreceptor RPE complex, primarily in the macular region of the retina, affecting the elderly population. There are various classifications available for the ARMD in the literature. Among these, conventional classification divides age-related macular degeneration into two forms: dry
the
or the
is going out of the field. Slide.
It's okay, doctor, please carry on.
dry or the non-neovascular age-related macular degeneration, and wet or neovascular age-related macular degeneration. Dry age-related macular degeneration is characterized by geographic atrophy, the death of the cells in the macula, and wet age-related macular degeneration is characterized by retinal pigment epithelium detachment and choroidal neovascularization. A wide varieties of studies have been performed to evaluate the association between serum uric acid and cataract and other chronic age-related diseases. However, yet no studies have demonstrated a significant association between age-related macular degeneration and raised serum uric acid, in spite of uric acid being widely described as having a significant role in its pathogenesis. Hence, our primary aim is to evaluate the relation between altered uric acid profile and age-related macular degeneration. This observational case control study was conducted in the upgraded Department of Ophthalmology, GMC Jammu, for a period of 6 months from January 2024 to June 2024. The study included 80 patients divided into two groups: 40 patients with age-related macular degenerations and 40 without age-related macular degeneration, which served as control groups. Participants were aged above 40 years of age group. All patients underwent a complete ophthalmic examination and serum uric acid levels were taken. Collected data was subjected to master tabulation in MS Excel spreadsheet, and SPSS 21 software was used for statistical analysis. A p-value of less than 0.05 was considered statistically significant. Inclusion criteria: age more than 40 years and presence of age-related macular degeneration. Exclusion criteria: patients with coexisting retinal pathology, systemic inflammatory disease, media opacities, and renal disease. So we have the results here. From the results we can see it was most commonly seen between the age group of 61 to 70 years, and about 15 cases presented with neovascular ARMD and 25 cases with non-neovascular AMD, and males were found to be 23, we could see ARMD in 23 males and 17 females in group 1, and 19 females and 21 males in group 2. and the serum uric acid level was in controls was about 5.2, and non-neovascular ARMD it was like 5.5, but we could see a major like relation, like in neovascular ARMD it was about 8.5 mg per deciliter, which was a significant level and showed us the association. Discussion: 40 eyes of 40 subjects with age-related macular degeneration and 40 eyes of 40 subjects as control were included in the study. The mean age of the patients presenting with age-related macular degeneration was 62 years and 65 years respectively. Similar age distribution was found in the study by Subramani et al. In our study, the average uric acid level was higher in the patients with neovascular age-related macular degeneration, which was 8.6 milligrams per deciliter, than in the non-neovascular age-related macular degeneration as compared to the control group. There was a significant difference of serum uric acid level in the patients with neovascular age-related macular degeneration than the control group. When comparing between non-neovascular age-related macular degeneration and control, no significant difference was seen. Similar results were noted by Subramani et al. In that study, mean serum uric acid level in age-related macular degeneration was 5.6, and that in control was 5.3 milligram per deciliter. In our study, serum uric acid levels were found to be higher in males compared to the females. Similar results were seen by Subramani and Dhawal et al. A statistically significant correlation exists between serum uric acid level and the severity of the age-related macular degenerations. Patients with neovascular age-related macular degeneration present with higher level of serum uric acid level as compared to the patients with non-neovascular age-related macular degeneration. Thank you.
Does the literature also say the same thing?
Yes, so we have several literature, like we have Davi et al., which took the study in 100 patients.
Use the mic.
They took 100 patients as controls and 100 patients as the patients who were having neovascular age-related macular degeneration, and they found that the non-neovascular group didn't have that association as compared to the neovascular ARMD. Neovascular ARMD had a significant association. And we have other Fisher et al., which was telling about the pathogenesis, like regarding the how serum uric acid is linked to the age-related macular degeneration. They have proposed that there are NR-LMP3 receptors, which are the they belong to the NOD-like receptor family group, and they are responsible for the pathogenesis of the neovascular.
So very nice. The study that you mentioned, Subramani et al., what was the power of the study?
Sir, what?
The power of the study, how many people did they study?
They had taken 80 patients.
80 patients. And there are more there is larger data available still?
Sir, in 100 patients, Dawal et al. Has done the study.
And similar results were obtained there as well?
Yeah, similar results.
So what is your take-home message over here? Okay, now you found this out.
We can use serum uric acid as a marker for the this neovascular age-related macular degeneration.
You can use AMD. Everybody knows AMD. You don't need to say the full form every time. No, but then now patients already have wet AMD. Now what is the sense in getting uric acid levels done? Suppose a patient, like you said, that these patients with dry AMD, the uric acid levels were comparable to the ones that did not. So is it worthwhile to keep checking that time to time as a marker perhaps?
Yeah. It is, because they may progress to the neovascular.
So do you do that?
Huh?
Do you do that?
We are in past
Maybe you can think, you can explore it. You can think about that. It has to be useful also.
Yeah.
Okay? Very good.
Okay.
Thank you, Dr. Sama. Now the next presentation is by Dr. Anashwa Kapoor on yellow laser photocoagulation of superficial and deep conjunctival nevi.
Good afternoon, everyone. So I will be presenting a case series on yellow laser photocoagulation of conjunctival nevus, a minimally invasive alternative to surgical excision. So more than 50% of conjunctival tumors are melanocytic tumors, and amongst them around 50% are conjunctival nevus. And conjunctival nevus, the diagnosis is usually clinical, where it is present since birth, usually unilateral, is very well defined in the interpalpebral location, limited to the limbus, has cysts, change in size happens at puberty, and there might be a feeder vessels. Further, we can go ahead and do an ASOCT to look for the cysts there. So in our study, we included clinically diagnosed cases of conjunctival nevus who were stable on size and color both for over the past 6 months, and performed laser photocoagulation with the help of Iridex yellow laser 577 nanometer. We looked on the follow-up visits, which were on day 1 week, 1 month and 3 months. We looked into the efficacy of the laser, whether the lesion went away with laser or not, and also the safety. The safety we assess with the help of the ocular keratograph, all the ocular surface disease index, the tear meniscus, the non-invasive tear film stability, lipid layer thickness, Shermer, Oxford corneal scoring, everything was looked into. And we also performed histopathology of the lasered conjunctiva wherever possible. So this was the very first patient, because this has never been reported in literature. So the first patient we chose was an anophthalmic socket where there was a deep nevus, and when we applied laser, what we found that initially there was a graying followed by some cavitation which was developing, and finally it was this blackened lesion which we could easily remove with the help of a cotton bud, and this is at 1 week follow-up you can see. We also sent the gray and blackened part for histopathology, and what we found out was that the gray part had considerable amount of viable nevus cells, and the percentage of nevus cell came down in the blackened part. This is the result, the 8 patients, this was a pilot study where the 8 patients, you can see that they were moderate to severely pigmented nevus, and we kept the spot size and the duration fixed, and the power we varied from 300 to 600 depending on the amount of pigmentation which was there. And we looked into the residual pigmentation at 3 months follow-up, and as you can see, 3 patients had mild pigmentation at the limbus, which was because we didn't laser the limbus. This was the first study we were doing. Maybe moving forward we will be lasering the limbus as well. So this is one particular patient. This is at 1 week. You can see the epithelial defect there, and over at 1 week and 1 month everything normalized. So the laser was 100% effective. By calling it effective, I mean that on applying the laser, the lesion was coming off nicely, but the limbal residual was there for 3 patients because we purposely didn't laser the limbus. There was no recurrence at 4 months follow-up. There was, apart from some congestion on POD1, there were no changes on ocular surface in all the parameters that we studied. So this is a review of literature. There are only 4 studies in literature, majorly from Korea, where you can see majority of them were just superficial lasers. So our study for the first time is done in India, and we have done it on all deeply pigmented nevus. And yellow laser photocoagulation is indeed a safe and effective outpatient procedure based on this pilot study. And there are no complications like scarring, tissue dragging, neovascularization, which usually happens with surgery. So just to summarize, the pros of laser photocoagulation over surgery are, it's just an OPD procedure, ensuring quick recovery, being cheap, can be done just under topical anesthesia. There are no significant side effects. The con being that there was no histopathology confirmation, because majorly whenever we send the histopathology sample, it was charred. So the pathologist couldn't come to a conclusive diagnosis there. So thank you everyone for a patient listening.
So it's very good presentation. In surgical excision, is there any report that they do excision with conjunctival autograft? Any report like that?
Excision of a conjunctival nevus?
Yes, in surgery.
Yeah.
Do they do
so
graft?
The standard of care is excision.
Excision, no
with
grafting?
conjunctival autograft or an amniotic membrane graft. That is depends on the surgeon how you want
So
to
if there is autograft, then scarring should not be there.
Yeah, but like there can be tissue dragging, as we see for CLAGs or AMG, that can be some neovascularization happens.
So is it more cosmetic in appearance than the surgery?
Yes, that's what our preliminary observations are, that it is
good. Thank
better to the standard of care surgical excision.
Very nice, Dr. Anisha, very novel. Now, these patients had only one sitting, or did they have multiple sittings?
So two of them, this is the first study, as I said, with yellow laser. So we were not sure of the laser parameters. We were titrating as we were going on. So two patients which were the huge nevuses, more than 4 millimeters on the greatest diameter. So we chose to space it out over a period of 1 week. So out of these 8 patients, 2 patients, we have done it over 2 sittings.
Excellent. I'm sure your patients are very happy with the outcome as well.
Yeah, as of now.
Thank you.
Thank you.
Thank you, Dr. Anashwa. Now the next presentation is by Dr. Mehrotra on Bright Horizons. Next presentation is by Afrin Bari.
Good afternoon, everyone. I am Dr. Afrin Bari, and I will be presenting you various clinical scenarios, an amalgam of surgical referrals that have come to our tertiary center, various abandoned cataract surgeries. Now, cataract-related complications are the second most common cause of blindness in patients aged more than 50 years. So we did a study where we analyzed the clinical presentation and management of cases that presented with abandoned cataract surgeries and were referred to our center. This was a retrospective interventional case series at Tertiary Eye Center, included cases that were referred for surgical management following abandoned cataract surgeries. Coming to the case scenarios one by one. The first case was a case that presented with atrophic iris, as we can see here, with the arrows as shown here, and the pupil was irregular, and we could appreciate that there was an incision. The surgeon had just made the incision and just come out and referred the patient to a higher center. So likely this was a case of pseudoexfoliation syndrome. So this was later managed by iris hooks assisted phacoemulsification with proper anti-glaucoma cover. The second case was a case of Descemet's membrane detachment with reticular epitheliopathy. This was the presenting feature. As we can see, this is the zoomed image where we can appreciate that there were reticular epitheliopathy, and AIOCMTC showed that there was a Descemet's scroll. So what we did was, in first stage we just injected intracameral air, and the epitheliopathy vanished and the edema settled down. This is the post-op image. And thereafter, in the second stage, the patient underwent cataract surgery. The third case scenario was a patient who underwent cataract surgery but did not complain of not gaining any vision after the surgery. So there was some complication which he could not tell, and he was just referred. So it looked like this. There was lens, and behind the lens there was a full retained cortical sheet, which was appreciated on anterior segment OCT, as we can appreciate here. So this patient was managed by bimanual irrigation and aspiration of the cortex, and post-surgery he gained vision. The fourth case was a case of brittle cornea syndrome, where the surgeon had no idea that he was dealing with a brittle cornea syndrome. He had just made the incision, and after incision, the incision itself started increasing along the limbus, and he just referred the case with flat AC, and there was lens endothelial touch. So we comprehensively planned the case for deep anterior lamellar keratoplasty and did a simultaneous cataract surgery. Post-operatively, the AC was formed. This was another case where the surgeon had just referred with stromal edema. So, and the wound was open. So as we entered the wound, we could appreciate that there was a scroll which was coming out. So likely this was the scene. As we went in, the Descemet scroll was coming out. So using microscope integrated OCT, it was appreciated, the Descemet scroll could be appreciated, and an auto DMEC was done. Intracameral air was injected after ensuring that the graft was in correct orientation. So from presentation, hand movement close to face, the patient reached to 6/6 with a clear cornea. I've added few videos. This was the case of Descemet's membrane detachment, where with the injection of intracameral air, we appreciate that the Descemet's membrane has attached due to the pressure from the gas. This is the second case which I already explained. Extruded Descemet's membrane. As we are injecting fluid, the Descemet's scroll has come out. So we again injected it back. And after appreciating the orientation, the correct orientation of the Descemet's scroll, we injected air, and on follow-up, the patient gained good vision. This is my last case where the patient was referred aphakic with the open leaky SICS wound, where there was vitreous and Descemet's membrane detachment at aphakia. Firstly, the wound was closed, anterior vitrectomy was done, and simultaneously scleral fixated IOL was planned. Firstly, this wound was there. First step was to close this wound. So this wound was closed, an incision anterior to it was made, and a 3-piece IOL was made after making the scleral flaps. So to conclude, a thorough preoperative assessment is very important, along with early identification of any of the intraoperative complication, along with timely referral by the primary surgeon. By the second surgeon, it is very important to act apt and prompt to improve the visual outcomes. Thank you.
Very nice presentation. In all your cases, you could manage DMD with air?
Yes, sir.
You didn't need any expansile gas?
So we did use SF6 in certain cases, it was preferred. Like in the case where the Descemet's membrane was superiorly detached, SF6 was preferred, because so that there was a longer tamponade for that case.
Okay.
However, in these cases we have to be careful there is a chance of pupillary block on post-operative day 1, so we have to accordingly titrate the amount of gas that we are injecting. So that is there.
So in the case where a thick epinuclear plate was there behind the IOL, how did you manage with bimanual?
Sir, 2 MVR incisions were made 180° apart, and then since the surgery was done fresh, so the lens was the capsular bag, we could go behind the capsular bag using the irrigation
behind the IOL, I meant.
Behind the IOL, yes, behind the IOL.
Did you orient the IOL in such a way that you can go easily behind the IOL?
Yes, sir. The aspiration was there behind the IOL, and the irrigation was there anterior to it, so that we could maintain the balance in the anterior chamber.
Good. Thank you very much.
Thank you, sir.
Thank you, Dr. Afrin. Now the next presentation is by Dr. Megha Ari on Bright Horizons, Understanding the Positive Prognosis of Pediatric Optic Neuritis.
Good afternoon, everyone. I'm presenting a case of a 6-year-old male. With a chief complaint of sudden onset painless profound loss of vision in the both eyes since 2 days. So the past medical history is that he had a prior high-grade fever with vomiting for 15 days, and he is a diagnosed case of Salmonella typhi fever. He was conservatively managed. There is no history of recent injury to head, seizure, headache, diplopia, persistent hiccups, weight loss, and vaccination. There is no significant medication history for any systemic disease was registered. The birth history, the growth and development of the child were normal. General examination, the child was average build, afebrile, fully alert with normal vitals. The systemic and the neurological examination were normal. Now coming on to the ocular examination, vision. In the right eye, the perception of light was doubtful. In the left eye, it was hand movement. Extraocular movements were full in all the cases. No pain on the eye movement was recorded. Pupillary reaction, it was ill-sustained pupillary constriction in the eye. Anterior segment in both eyes, they were within normal limit. This is the fundus examination of the both eye, which is within normal limits. There is no any disc pallor seen in this. Now the investigation. On the investigation, the total leukocyte count was found to be 19,100. The ESR was 45 mm, which was raised. The Vidal titer was significantly raised. Blood sugar, antibodies like ANA, MOG and NMO, and VDRL, liver function test, and urine routine microscopy, Montague's test, and chest X-ray, they were not significant. They were within the normal limits. Now on brain, doing the MRI of brain in orbit, it showed the brain MRI was within normal limits. But on the MRI of orbit, it showed bilateral enhancement and thickening of the optic nerve, which was suggestive of optic neuritis. So the diagnosis of post-typhoid simultaneous bilateral retrobulbar optic neuritis was made. Treatment: the patient was started on intravenous methylprednisolone, which was 25 mg per kg per day for 3 consecutive days, followed by oral corticosteroid at a dose of 1 mg per kg per day, which was tapered gradually over a period of 4 weeks after pediatric consultation. And the result: post initiation of the treatment on the day 4, the best corrected visual acuity was 6/60 in the right eye and 4/60 in the left eye, which improved to 6/12 in right eye and 6/18 in the left eye after 2 weeks. The pupillary reaction also became normal in both eyes. Also, there was a significant reduction in the Vidal titer of the patient. After 1 month, the best corrected visual acuity was 6/6 partial in the right eye with 6/9 in the left eye. So the take-home message from this is pediatric optic neuritis is pretty uncommon. It usually presents with bilateral presentation, and mostly the anterior part of the optic nerve is involved. It is treated in the similar way with steroids as in adults according to the optic neuritis treatment trial. The thing is important, which is to be noted, is that it has got a better visual prognosis than as compared to adults. So their diagnosis, early diagnosis is very important. Thank you so much.
So what is your thinking about why children are having better prognosis than adults?
Sir,
just a finding.
So just a finding, so that they have better visual prognosis.
Don't be nervous. Think and speak. Okay, so very nice presentation. He's also coming. So very nice presentation. I missed a few slides. Your treatment over here was Bisolone, I'm sure.
So IV methylprednisolone for 3 days, first of all.
Sorry?
So it was intravenous methylprednisolone.
So IVMP.
Yes,
and what was the dose?
So
How
the
old
dose
was
was
this?
25.
This is just one patient, right?
So this is just one patient.
Okay, and
so
how,
the dose
what was the age of the patient?
It's a 6-year-old.
6 year. And how much was the dose that you given?
Sir, intravenous it was given 25 mg per kg, and the oral dose was 1 mg per kg.
25 mg per kg.
Per kg per day.
And again, to rephrase what Dr. Mohanta was asking, why do you feel that the prognosis is it better in children as compared to adults? It's pretty good in adults as well. So I mean, it's inadequate data to say that it's better than adults. What about any imaging? Did you also do any imaging?
Yes, sir. We did imaging, MRI, brain in orbit. Brain, it was normal.
Okay.
And
you had shown it?
Yes, sir.
Okay.
So there is bilateral enhancement and thickening of the optic nerve.
Okay. Thank you.
Thank you. Thank you, Dr. Megha. Now the next presentation is by Dr. Amit Parwal on correlation of choroidal thickness with refractive error and axial length in Indian eyes.
So, good afternoon team UKSOS and AIOS. It's a privilege to be presenting in this session. So I'm talking about correlation of choroidal thickness with refractive error in axial length in Indian eyes. We don't have any data in the Indian eyes. So to briefly introduce, choroidal thickness is emerging as an important factor for predicting myopia progression. We are presenting normative data of choroidal thickness and its comparison with various refractive error and axial length in Indian population. So the purpose of the study was to study the normative data of choroidal thickness in Indian population. It was a prospective non-randomized study in which 516 eyes of 258 patients were included. IOL Master 700 and Zeiss Angioplex OCT machine was used for measurement of axial length and choroidal thickness respectively. Based on the refractive error and axial length, patients were divided into 3 groups, that is emetrope, hypermetropes and myopes. Group emetrope with either or no refractive error or plus or minus 0.5 diopter with an axial length between 21.51 to 23.5 millimeters. Hyperope more than plus 0.5 diopter and axial length less than 21.5 millimeter, and group myope was with a refractive error of more than minus 0.5 and axial length of 23.5 and above. So when we look at the results, the mean age of the patients were 24.61 years, male-female ratio was 146:112. Total E-metrope patients were 88 with mean axial length of 22.14. Hyperopes were 56 patients with mean axial length of 20.81. Myopes were 114 patients. Out of this, a separate group of 22 patients with axial length of more than 26 and or refractive error of more than -6 diopter were made as high myopes. So mean choroidal thickness in E-metrope, which was 176 eyes, hyperopes and low myopes was 270.15, 269.5 and 268.1 microns respectively. There is no significant difference between the three groups in the choroidal thickness. In patients with high myopia, that is axial length more than 26 or more than -6 diopters, the choroidal thickness was 221.17. So these were the measurements which were done on the IOL master and the scans on the angioplex machine. So coming to the discussion, in the early experiment on primates, it was found that in marmoset, the thickness of the choroid increases during postnatal eye growth. Superimposed on this developmental increase in choroidal thickness, there are changes in thickness that are correlated with induced changes in the eye size. Proseri et al. In the study found that myopic eyes have thinner choroids compared to emetrope and hypermetropic eyes. Choroidal thickness may in fact serve as a marker for myopic progression, as choroidal thinning occurs early during the myopic development, but this association has not been established quantitatively. So in addition, the subfoveal choroidal thickness appears thicker in amblyopic eyes, while prematurity and retinopathy of prematurity may be associated with thinner choroidal thickness. Overall, both animal models and clinical research indicate that choroidal thickness induces or reflects physiological changes in the eye pertaining to ocular growth or maturation. So there is dramatic thinning of the choroid in high myopes, and associations are also observed between choroidal thinning and reduced vision and the development of retinal pathology associated with high myopia. In the short term, environmental factors known to be associated with myopia development and more rapid eye growth typically lead to a thinning of the choroid, whereas factors linked to slowing of the eye growth are typically associated with short-term choroidal thickening. So although a lot of emphasis has been put on this retinal thickness and axial length of progression of myopia, it is possible that choroid may have the answers for the same. In another report, choroidal thickness but not the retinal thickness correlated closely with the axial length and refractive diopters in Chinese children. Choroidal thinning occurs before retinal thinning early in myopia progression. So our study clearly shows when the refractive error is comparable, the choroidal thickness holds on. However, the axial length starts correlating with the thinning of the choroid once the axial length is around 24.5. So it would be imperative for future work to find out the critical anteroposterior size of the eye along with the choroidal thickness in the longitudinal follow-up of these patients or children. So to conclude, choroidal thickness in our study was comparable till the axial length was less than 24.5, and with the axial length more than 24.5, it correlated with the choroidal thinning. So these are the references, and thank you.
Nice presentation, Amit.
Thank you.
So what take-home message would we give to the audience, Dr. Purwal?
So take-home message, basically what we are right now checking for myopia progression is only through the axial length. So we are checking the axial length, and if there is increase in the axial length, we are thinking that it is a myopia progression, and then we start the atropine therapy or myopia control therapy. So before the axial length changes, the choroidal thinning occurs. So what we need to do is we need to check the choroidal thickness also along with the axial length. So if the axial length is stable, but if the choroidal thickness has decreased, then that is a sign that this eye is progressing and we should initiate the myopia progression therapy. And we have studies about this myopia progression choroidal thickness with the Western literature, but we don't have the Indian data of the choroidal thickness. So this was the first study done in which we had the Indian data of choroidal thickness. So this study is again continued. We have now, because it was very difficult to find high hypermetropes, the normative data. So now we have done 300 patient study in which 100 eyes of each section is taken. And we have found out that in high myopia, the choroidal thinning does occur, and that is an earlier sign than the axial length progression. So we should check the choroidal thickness to look for myopia progression.
Thank you. Thank you. And he just came in after completing a live surgery and then gave us a podium presentation. Thank you.
Thank you, Dr. Amit. So with this last presentation, a very interesting session has come to an end. The result will be out shortly. I want to thank everyone, all the presenters and our respected judges for their valuable inputs, and thank you so much. So we can.
Yes, thank you, Dr. Bandana, for conducting this session immaculately. Thank you, everybody.
Thank you, everyone.
Or if you want, we can. If you want, we can do a group. You can announce it.
All the presenters, please come for one group photograph, please, with the judges and all the presenters also.
ताकि वो लोग भी आ सकें। अच्छा एक हमारे ले लो आज एक हमारी ले लो ये तो पार्शलिटी होगी ना एक ही पर क्या कहते हैं हमारे स्पीकर हमारे साथ आ गया जब इसके मार्क्स कटेंगे. Come, everybody, all the speakers, whoever are there. Front row, speakers front row. Yes. ज़्यादा लोग हैं नहीं. अच्छा. ये बैकग्राउंड के में आ रहा है. आ जाओ और अंदर आ जाओ. Come, ma'am, come inside. Come. आपको तो बीच में आना चाहिए. Come. जैसा आप ले लो. अपने हाथ गट्टर पे डाल. Thank you.